All right, welcome everybody. This is our sixth podcast in our Pediatric Hospital Medicine series. Let me do my disclaimer. This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for patients. Just to remind you, my name is Dr. Tony Tarchichi. I'm an assistant professor here at the University of Pittsburgh, Children's Hospital of Pittsburgh of UPMC. This is our Pediatric Hospital Medicine podcast series. I am here for the first time with someone not from Pittsburgh. Hopefully the first of many, we'll see. The topic today is choosing wisely in pediatrics, safely doing less. I know I promised everyone toxicology, but we've moved things around and we'll get into that at the end. But I want to introduce my guest today is Dr. Ricardo Quinonez. Dr. Quinonez completed his medical training at the University of San Carlos in Guatemala City and pediatric residency at Baylor College of Medicine, Texas Children's Hospital in Houston, Texas. He's an associate professor of pediatrics at Baylor College of Medicine and chief of the section of pediatric hospital medicine at Texas Children's Hospital in Houston. Dr. Quinonez is an elected member and immediate past chair of the Executive Committee for the Section of Hospital Medicine of the American Academy of Pediatrics, where he also serves as a steering committee member of the Value and Inpatient Pediatrics Network. He's also co-chair of the Academic Pediatric Association's Quality Improvement and High Value Care interest groups. He's served in national panels assessing quality indicators for pediatric conditions ranging from IBD to respiratory illnesses, including as a member of the Standing Pediatrics Committee of the National Quality Forum. His main interest is in the issue of overuse and medical tests and therapies in pediatrics. And he led the first pediatric effort for the American Board of Internal Medicine's Foundation's Choosing Wisely campaign and has authored several publications on the issue of value in healthcare and conducted numerous national and international presentations. So, Dr. Quinonez, welcome to the podcast.
Well, thank you so much, Tony. I'm very happy to be joining you in this. I would have to say this is the first for me, but I'm very happy to be talking about my favorite subject here with you today.
And right before we get started, Tony, I would be remiss if I didn't thank my collaborators, many of whom have provided a lot of the data that you're going to hear today, a lot of the ideas that you're going to hear today. Most importantly, Alan Schroeder, who actually coined the phrase safely doing less in one of the publications that we're going to discuss today. I consider him a friend, collaborator, and mentor. And Eric Kuhn, who has worked with us, particularly in the area of overdiagnosis, and Sean Ralston, who's very interested in this topic and has provided some of the data that we're going to discuss today and has published on the subject as well. I really would like to thank them because you're going to hear a lot of what they have to say here today as well.
Oh, well, thanks. Now, let's do our conflict of interest. I have nothing to disclose.
And I have no conflict of interest to disclose.
All right. I think it's a first for both of us. First time I'm using Skype on a podcast, so this should hopefully go well. So Dr. Quinonez, let me start out by asking you a quick question. What got you interested in this topic? This isn't a topic I see people go into regularly.
Yeah, so that's a great way to start because that's usually the way I start my talks because You're right. This is not a topic that's usually covered in medicine and particularly in pediatrics. So I always tell people how I got interested in it. And I would say that I have always considered myself in my practice to be very non-interventional, a minimalist, if you will, in my actual clinical practice. But I was really interested in this as a academic issue when I read back in 2011, there was a publication of an opinion piece by one of my main collaborators, Alan Schroeder, who is a hospitalist in the West Coast in Stanford. He published an opinion piece along with Tom Newman where they were talking about this concept of safely doing less. And they particularly were talking about how this concept applied to the issue of patient safety. By then, the Academy of Pediatrics had published a pediatric safety policy statement, and it was a critique of the policy statement. And what Dr. Schroeder was trying to say in this critique was that we have been talking about a lot of things that we should do for patient safety in order to improve patient safety. but we almost never talk about the things that we should avoid to improve patient safety, to improve the quality of care that we provide. Just to give you some of the quotations from their work, they put things like, often the best way to avoid preventable harm from medical interventions is to avoid the interventions in the first place. So meaning if you don't do something that is completely unnecessary, then you're not going to cause any harm. And they even said that even well-intended and safely delivered healthcare can cause harm. So that really resonated with me because, this was already my practice style, but I had never been able to put a name to it. And that's where I really learned the term overuse and what it meant and what it meant for patients.
So do you think this is a topic that's more suited for a hospitalist because we have access to ordering MRIs, lots of interventions, just regular blood work? Is this something we should be a part of our training?
Yes. You look at the hospitalist competencies, which I know you've covered in your podcast before. Value in healthcare, which is really what this topic is all about, is one of them. But I think you're right. I think that hospitalists in particular, not just in pediatrics, but in adult medicine, have really championed this message. And I think it's because we often see patients in which overuse of medical therapies or over-treatment with medications or the overuse of labs and diagnostic imaging has led to an untoward event. And so because we see this often in the hospital, and because we do indeed have access to so many things in the hospital, this is a subject that really, in pediatrics in particular, has been championed by hospitalists.
So, Ricardo, this seems like something that's not just of local importance. This is really nationally important, that we really should all be talking about this as a country.
Oh, absolutely. And the conversation has been at a national level. And I think, we're pediatricians, and so we haven't heard it as much because if you think about it, in pediatrics, we often talk about underuse of vaccines, underuse or lack of access to care by children. But we often don't hear about this topic. But in adult medicine, it has been discussed a lot and has led to a national conversation. And it's partly because if you look at the numbers, really, they're staggering, right? So in the U.S., we spend a lot of money. Our GDP to healthcare expenditure is the highest of any industrialized country. And really nobody would be objecting to that if we got a lot for it. But we're not number one in infant mortality. We're not number one in life expectancy. As a matter of fact, in life expectancy, we're behind 19 other industrialized countries that spend a lot less than we do. Let me just give you one example of the expenditures that we use in this country. Let's look at MRI per 1 million persons. In the U.S., we get about 26.5 MRIs per million people, and that's almost double the next industrialized country. Switzerland gets 14. Now, again, if we had better outcomes and we were spending more, then this would be justified, but we don't. And so why don't we? What's the reason? Well, there's many theories, but one of those theories has been called the law of diminishing returns, which is basically, it has been seen in other things, and this is just applied to healthcare, but basically is if you have a primitive healthcare system and you start providing a lot of inputs into that healthcare system, you provide, in other words, you provide a lot of dollars and a lot of expenditure into that primitive healthcare system, then you get a lot of return. You basically see a curve that's tilting upwards, and you get a lot of initial benefit. But at some point, those inputs and as you plot them against benefit, they really start flattening out. And as a matter of fact, at some point, not only does it flatten out, but maybe it starts going down again. And I think that's the point we're at in the U.S., where a lot of the inputs that we put into healthcare are into these new technologies, new treatments, but a lot of preventive care, et cetera, is being put by the wayside. And so we're actually not only not getting better outcomes, but we're potentially getting worse outcomes.
Can I ask, is that corrected for things like the obesity epidemic, et cetera? Is that factored into it? Or even with all of that's going on, the obesity epidemic, et cetera, with the amount of money we're putting in, we should expect an improvement in healthcare. Is that right?
Well, I think it's just a matter of where you put those dollars, right? I mean, I gave you the statistics about MRIs. We don't need that many MRIs. That means that probably the amount of expenditure that we're using to get these really expensive tests could be used for things like obesity prevention, where there's not much dollars being spent currently, right? And so I think it's not a matter of the amount you spend so much as to where you're using those dollars. And really in the US, in the last few years, I would say the last 50 years, we really haven't placed a lot of emphasis on prevention, a lot of emphasis on those really good things in medicine that we could be doing to prevent bad outcomes. And the expenditure seems to be on newer technology, newer things that really haven't been proven to be absolutely necessary to improve the healthcare of the population overall. And, you know, what drives, if you want to ask it that way, what drives this expenditure and what drives overuse in general? I think in order for us to talk about that, I think we really need to get some definition. So what is overuse? Well, you know, it has been defined in many ways, but generally it's when we provide healthcare when the risk of harm exceed the potential benefit. When those benefits that you get from the healthcare you're providing are negligible, or when fully informed patients would likely forego that care. And it usually is divided into two things: overdiagnosis and overtreatment. Overtreatment is treatment that includes overdiagnosed conditions that will never cause symptoms or morbidity, treatment that is futile, treatment that has minimal evidence of benefit for the specific indications, or it's excessive relative to alternative accepted standards. And really there's many things that drive the overuse. I think the one that you hear doctors talk about the most is fear of litigation, right? So defensive medicine, basically doctors really not wanting to get sued. But when you really study whether fear of litigation leads to a lot of treatment, overuse, it really doesn't pan out. For example, you know, you would think that if litigation is causing a lot of overuse, overtreatment, then those states where litigation is limited, they would spend less. So for example, here in my state of Texas, we have instituted what is called tort reform, where we really limit the amount that plaintiffs can get when they sue physicians. And it's difficult. It's a lot more difficult to sue physicians here in Texas. And so you would think that we would spend less, and that's not the case. So several studies have shown that states where tort reform has been instituted, we have failed to decrease overuse and cost. And so we say that fear of litigation can lead to a lot of treatment and overuse, but that doesn't really seem to be the case.
Ricardo, here a question I have that just came up while you were talking. I know tort reform or fear of litigation is always kicked around as a cause of excessive overuse and overdiagnosis and overtreatment. What about in pediatric hospitals, especially the tertiary care, bigger pediatric hospitals like Pittsburgh, like where you're at in Houston, where you end up seeing the rarest of the rare cases, the 1 in 500 in the world of whatever genetic disorder? I feel like that has to have an impact on your practice, meaning you begin looking for those extremely rare diagnoses and maybe then over-diagnosing or over-testing. Has there been anything written on that? Have you seen that, specifically in the bigger centers?
Yes, and I know exactly what you're talking about. And really, one of the things that I always talk about whenever I talk about overuse is that, and I use a quote from a famous physician, Sir William Osler, where he talked about that we are constantly misled by the ease of which our minds fall into the ruts of one or two experiences. And so that's, I think, a little bit of what you're talking about, which is, you know, in centers such as ours, we see those very rare things, those complications that happen once in a million patients. And so we remember those, right? We truly do remember those. And what is the reason that drives us to remember those? And I think this is another driver of overuse, which you have brought up, which is basically that we give errors of omission a heavier weight than errors of commission. And let me give you an example of this. If you live in the New York area, you know who Rory Staunton is, particularly if you practice medicine in the New York area. Rory Staunton was a child died several years ago in New York, and he died from sepsis. The sepsis, he presented to an ER with sepsis. It was missed. He was sent home, and he came back and was in septic shock, and he didn't make it, unfortunately. His death was tragic. He was killed by an infection. He was killed probably because of a laboratory test that was missed. So that was an error of omission, right? We failed to do something, and he died from sepsis. And that error of omission actually led to a lot of action. It led to more than 10 New York Times articles. It led to a New York law, which states that you have to have a sepsis protocol. If you go to in an ER in New York, you have to have a sepsis protocol. And it has spurred national action, right? I don't know if you in your hospital, Tony, have done this, but we have, we're participating in a sepsis campaign here at Texas Children's, as are many other hospitals around the country, sepsis collaboratives to try to develop these best practices to never miss sepsis in children.
We're doing the same thing. We're doing the same exact thing.
Absolutely, and it all came out of this unfortunate child's death. So I would argue that error of omission has led to a lot of good action. But what about the other side of this? What about errors of commission? Several children per year die from wisdom tooth extractions, from just the simple wisdom tooth extractions, and about 70% of those wisdom tooth extractions are unnecessary. There's publications that have shown that. Jenny Olnick and Ben Ellis were two of these children, but you really never heard about them. I mean, unless you lived in the localities where this happened. It didn't lead to the kind of action that Rory Staunton's death led to. It didn't lead to any New York Times articles, and it didn't lead to wide media coverage, and it certainly didn't lead to any laws. These children were killed by healthcare. They were killed by errors of commission. Right? They were killed by something we did that was probably unnecessary. Like I said, 70% of wisdom tooth extractions in this country are unnecessary. So we just don't give errors of commission the same due that we give errors of omission. Let me give you one more national example that I think where you really see this. In 2012, we had this epidemic, or we had this terrible epidemic of fungal meningitis that happened when patients were injected with this tainted medication. They were given epidural injections from tainted medications that was mixed incorrectly or in not very aseptic conditions at this pharmacy. And it made national news, it made international news. And everything you heard about this was the terrible septic conditions that occurred at this compounding pharmacy, terrible the conditions were inside, and how this should have never happened. And that conversation was an appropriate conversation because it certainly led to deaths. It certainly led to a lot of morbidity and mortality. But the conversation that you never heard, that was reported by some people, but that wasn't really reported widely, was that in almost every single case, these injections were not indicated. The medicine was used to treat back pain or other conditions in which those injections, there was no evidence basis for their use. In fact, in some cases, it wasn't even like the third or fourth line of treatment for this. So it was used by physicians who were not using evidence to drive their treatments. It was over-treatment, overuse. Arguably, these patients would be just as alive and these infections would not have occurred if physicians didn't practice in this way. So that was another error of commission and an error of omission. But you only heard the error of omission. You didn't hear much about the error of commission, and I think that happens all the time.
So when you're saying error of commission, you're meaning the error of us doing something that perhaps was unnecessary to do. Absolutely. And a lot of the time, the reason why we don't hear about the error of commission is because the consequences of errors of commission are not as immediate as the two examples that I just gave you. The consequences of errors of commissions can be more long-term, right? So if I get an unnecessary CT on a child because of a minor head injury, well, that error of commission, the consequences of it, you may not see it years later until that child's developed brain cancer from an unnecessary CT.
But years later, nobody's going to tie it back to the original inciting event, right? Because it doesn't happen immediately. And this happens all the time in medicine. The consequences of things we do have long-term consequences and not immediate consequences. And so usually things that we fail to do are the ones that have more immediate consequence, but they're both just as wrong. And so I think this is one of those things that drives overuse, and I think it's a little bit of what you were getting at with your original question.
Yeah, that was great.
So, another thing I would say that in the hospital we have supply-sensitive care, which is another sort of these drivers of overuse. This was first really, it took off back in the 70s when John Weinberg did an epidemiologic study in Vermont, and he started studying healthcare in Vermont, and he noticed that tonsillectomy rates in two different Vermont cities that were really close to each other were very different. In Middlebury, Vermont, only about 7% of children got tonsillectomies, and in Morrisville, Vermont, which was just down the road, about 70% of kids got tonsillectomies. Really, for no reason whatsoever, right? I mean, kids in Morrisville weren't any sicker than kids in Middlebury. So he started studying why that could be. And what John Weinberg found was that, there really was no reason. That it was because the ear, nose, throat doctors, ENT physicians, really just prefer to do tonsillectomies in Morrisville, and the ENT physicians in Middlebury didn't. So it was really just unwarranted variation, and they had more ENT physicians in one town than others. So that's supply sensitive care, and this led to what we now know as the Dartmouth Atlas, right, which tracks healthcare expenditure and usage in the U.S. And really, one of the first examples of overuse, which the Dartmouth Atlas found, was a pediatric example. And so I think that's one of the reasons we should embrace this topic in pediatrics, because a pediatric example, or this example of tonsillectomies, was one of the first that really saw this.
It's not something I'm proud that we're a part of, but I think it's great. It's really great to hear.
Yeah, I mean, I think there's lots of lessons to be learned from things that we've studied in pediatrics. But, the Dartmouth Atlas has led really to find some of the other drivers of overuse. And one of these is the way physicians are compensated. I don't know if you remember this famous piece in the New Yorker called The Cost Conundrum that was by Atul Gawande. And basically it studied two Texas towns. It studied El Paso and McAllen, which are two border towns here in Texas. The populations are almost equivalent. They are really very similar to each other. But Atul Gawande, through studying the Dartmouth Atlas, really, he found that Medicare expenditures in one town versus the other was twice as much per beneficiary. And really, this was kind of weird because, like I said, they're very similar towns. They look exactly like each other. The populations are no different. So why would you spend more money in one versus the other? And so he went down to investigate what the reason was. And what he found was just kind of staggering. And it was the fact that in El Paso, it was more of a managed healthcare system where, physicians didn't get paid more if they did more tests. Whereas McAllen, it was the complete opposite. Physicians owned the labs. Physicians owned the hospitals. They owned all the clinics. And so doing tests, doing more hospitalizations, or getting more x-rays, that directly led to more profit. And so it was a profit-driven increase in healthcare expenditure. And so that's another, the way we are compensated as physicians is another driver of overuse.
And I'm going to assume from everything you've said that there was no difference in the healthiness of one population versus another.
You got it. That's right. There was no difference in outcomes. Absolutely not. No difference in quality of life. They didn't live longer in McAllen or in El Paso. We just spent more to get the same results. So I think there's lots of drivers. I think one of them certainly, which is very prevalent still today, is publication bias. Whenever you read any medical journals, almost all of the publications in a medical journal are what you would call positive studies, or meaning the investigators were trying to prove a theory, and they proved it. And so, that they were trying a new treatment and it worked.
we don't see as many negative studies, and arguably these are just as important, right? We want to know what doesn't work. We want to know what doesn't work in healthcare because we don't want to be using it. And so publication bias can really be a significant driver of overuse. Let me give you a very pertinent example to pediatrics. Back in 2012, although the recommendation was across the board, it included pediatrics, right? But back in 2012, the CDC, IDS, Infectious Disease Society of America, and several other organizations, including the AAP, recommended Tamiflu for the treatment of influenza early in the course. And because of the H1N1 epidemic, several governments started stockpiling this medication, including the U.S., at a cost of several $billions, right? Because they thought, this medication is probably effective in treating a very likely potential epidemic of pandemic flu. Well, the reason these recommendations were made was based on, on a Cochrane review back on 2012, which, found a small positive effect on symptoms, duration, and complications. But, in that same review, the authors reported that they were unable to obtain the full set of clinical study reports from the manufacturers of the medication, meaning the full set of study reports, not just what was published in the literature, but the full set of clinical reports, including those things that might not have been published. Well, what we learned later on an updated Cochrane review, after about 8 unpublished studies were obtained, what we found was that when you looked at these 8 unpublished studies, which were just as good in quality as those that had been published, there was no difference in duration of symptoms and difference in complications, and there was really no difference in complication rates such as hospitalization or pneumonia for anyone, including children. But now it was too late, right? It was already recommended to be used. It was already stockpiled. And the updated Cochrane now tells us that there's insufficient evidence for complication prevention or hospitalization when you use Tamiflu. But the other side of this is that when you look at the unpublished studies, there's a significant number of adverse events when you use this drug: nausea, vomiting, and really significant psychiatric events and renal complications that were, somehow left off the initial published things. So publication bias and unpublished reports by manufacturers really can lead to a lot of overuse because we start using things that we think are effective that might have questionable benefit or no benefit at all.
So has anyone ever done a study looking at if all of these biases were eliminated, how much of a decrease in healthcare expenditures would we see? Or is that just too theoretical to even really do at this point?
I think it's too many questions to do in one study. But I think what you have to do is look at places where this type of medicine is not practiced, right? So I think looking at other healthcare systems where, for example, the compensations of physicians is not done on a fee-for-service, where, evidence drives more of what we do with healthcare expenditure. And I think countries in Europe are good examples of ways in which this can be accomplished. Is it perfect? Absolutely not. But certainly in places such as Europe or Canada, where they spend a lot less in healthcare, but get similar, if not better, outcomes that we do. Those are natural experiments. So when you eliminate these types of drivers, can be done better. Now, publication bias, that's something that affects everyone in medicine, not just, it's hard. That one's a little bit hard, and there's a lot of people working to publish negative studies, and I think a lot of investigators have been encouraged to publish negative studies. For example, one of the things that the British Medical Journal now requires of all its authors, if they want to publish a randomized controlled trial and the results of an RCT in their journal, they have to submit the whole study report. And why do they have to submit the whole study report? Because they want independent investigators to be able to replicate and re-examine their data, right? Not just have one interpretation of the data, but re-examine the data. And they have really been at the forefront of this requirement for publication in medical literature. And there's a call for all journals to do something similar to this. and the movement is called data transparency. And I think a lot of journals here in the U.S. are really looking hard at this and starting to think about whether this is a good idea or not.
Have we seen that in any of the pediatric journals? Pediatrics, Peds in Review, the bigger ones?
Full disclosure, I am a member of the editorial board of Pediatrics, and we actually have discussed this, and I think Pediatrics is probably going to move forward with data transparency, but none of the current U.S. journals, U.S.-based journals, have this requirement to the extent that some of the European journals, in particular the BMJ, does. So I think I've talked about some of the drivers of overuse, and I defined overuse, right? And I said that overuse is both over treatment and over diagnosis, and I think I mostly talked about really examples and giving you examples of over treatment. But I really wanted to talk about a little bit about this concept of overdiagnosis. And the reason why I like to talk about it separately from everything else is because the concept of overdiagnosis is really a concept that is difficult for even seasoned clinicians to understand. It took me some time to truly understand what it meant. I mean, we've all heard the term overdiagnosis being used, but I think we've heard it being used incorrectly. So what is overdiagnosis? Well, it was really defined by Gilbert Welch, who's an internal medicine physician. He wrote a book called Overdiagnose. And he said that overdiagnosis is the detection of conditions that would not have caused harm. Basically, detection of conditions where detecting them does not benefit the patient, or the benefits of the detection really do not outweigh the harms. So a simple way to look at this is overdiagnosis is a correct diagnosis, but one that does not benefit the patient. Now think about that. That's really a difficult concept for physicians to grasp, because we have been taught forever that one of the most important things that we need to do in medicine is to make a diagnosis, right? From the very first time, I'm sure you'll remember, Tony, and in medical school, the way we were taught is you have a set of symptoms, of signs, and what do you do with that? You try to put together a differential diagnosis based on that, right?
Right.
And so making a diagnosis is highly emphasized in healthcare, right? So this concept that actually making a correct diagnosis could be harmful is really a novel concept, but really, when you really look at it, it actually makes sense. So overdiagnosis is not misdiagnosis, it's not a false positive. It's an actual diagnosis, but making that diagnosis can cause harm. And so how do we know? Well, there's examples. There's clear examples in medicine. One of the best examples of this is prostate cancer. And it's one of the better studied examples. We can easily diagnose prostate cancer, right? There's a test called a prostatic specific antigen. And this test, back when it was first developed, there was a lot of excitement about this. And the reason there was a lot of excitement about this is because it was sort of like the panacea of cancer detection, right? It was a very non-invasive test that you could do in blood. So basically all you needed was to do a blood draw. And you could detect cancer early on. You could detect this protein that told you that the likelihood of a patient having cancer was high. And so there was a lot of excitement about this. A lot of once it was shown that it could actually detect prostate cancer, there was a lot of medical societies recommended its use, etc. But the problem is that there were no randomized control trials that showed whether actually using this test led to better outcomes. Well, 30 years after we started screening people for prostate cancer, the first randomized control trials came out, one from the US, one from Europe, looking at the PSA in particular, and it really found that there was no difference in mortality when you divided men into getting a PSA and not getting a PSA. And, that really was very surprising, right? I mean, this test that adequately detects cancer early on did not lead to better outcomes when it was studied extensively through randomized control trials. And this type of thing, we've seen it time and time again. Let me give you an example in pediatrics. In pediatrics, back in the 1980s, we decided that we wanted to study whether detecting neuroblastoma early on would be a good idea. So several countries, not including the U.S., but some European countries, decided to start screening children for neuroblastoma. And the reason for neuroblastoma is because just like prostate cancer, you can detect it in a very non-invasive way, right? You can test the urine for catecholamines. And if catecholamines are increased in the urine, that leads you to believe that the chance of having a neuroblastoma is high, and then you can do whatever test you need to do to detect whether the child has neuroblastoma or not. And what happened? Well, the smart thing was that unlike prostate cancer, they started studying this right away. So basically, they started doing randomized control trials of the screening of neuroblastoma. And what they found really quickly was that not only did neuroblastoma screening not lead to better outcomes, it actually, in some places where it was, the kids who were screened had worse outcomes. So what is going on here? Why is detecting prostate cancer early and detecting neuroblastoma early not beneficial? Well, what happens is these screening tests are not able to differentiate between cancers that we actually care about, those that are likely to cause mortality or morbidity, and those that will be undetected forever, or those that, in the case of neuroblastomas, will just involute on their own. So, for example, in neuroblastomas, what they detected was really early neuroblastomas, and we know that the natural history of some neuroblastomas is that some of them involute on their own. They never progress to stage 2, stage 3, stage 4. They stay at stage 1, and then the immune system takes care of it. Well, in the case of prostate cancer is incredibly common. 80% of 80-year-olds have prostate cancer. So when something is that common and you have a test that is very sensitive at detecting it, we're going to be detecting a lot of cancers that would have never caused a problem in the first place. And the test is not good at discriminating whether it's one of these that will never cause harm in the first place or one of the others which will cause harm. So it just doesn't help. These were clear examples of overdiagnosis. These patients actually had cancer. They actually had neuroblastoma. They actually had prostate cancer. But knowing that did not help the majority of them, because in many cases, they would have never known they had it. It would have either gone away on its own, or, it's in the case of prostate cancer, they would have lived a full life never knowing they had it, never having symptoms from it. But once detected, these cancers lead to a lot of treatment, a lot of biopsies, a lot of harm, basically. So these are clear examples of overdiagnosis, right? I mean, they were studied through randomized control trials. The randomized control trials of doing it versus not doing it showed that diagnosing this early did not lead to an advantage, at least through the tests that were done. And so these were clear examples of overdiagnosis. And so, with some collaborators and I, Alan Schroeder being one of them, Eric Kuhn, who is a pediatric hospitalist in Utah, and Virginia Moyer, who at one point led the United States Preventive Services Task Force and now works for the American Board of Pediatrics, we decided to study overdiagnosis in pediatrics. And what we decided to study was, well, are there examples of overdiagnosis in pediatrics that people have not talked about before as overdiagnosis? Now, we had the clear example of neuroblastoma, which I just told you about, but we thought there were probably others, right? And sure enough, we started looking at the literature, and we found what we thought were really various examples of overdiagnosis in pediatrics. And, we found things such as gastroesophageal reflux, urinary tract infections, bacteremia in children, hyperbilirubinemia, hypercholesterolemia, that there's clear evidence in the literature of overdiagnosis, but people have just never really called it that, right? Skull fractures in kids who have minor head injuries. Again, examples of actual diagnosis, but that have not led to better outcomes. And, we published this paper back in 2014. We called it Overdiagnosis, How Our Compulsion for Diagnosis May Be Harming Children. And, some of the examples that we pointed to as there being some evidence for their overdiagnosis in the literature have now really been studied better, and really we feel have, in many cases, have been shown that they truly are examples of overdiagnosis.
So when you say bacteremia and UTI, that's striking. Are you talking about bacteremia like contamination, so coag-negative staph that's not really, came from the skin, that's not really a bacteremia, or do you mean real bacteremia?
Real bacteremia, because remember, overdiagnosis is an actual diagnosis, right? Okay. Not a misdiagnosis, not a false positive like that would be, right? So we're talking about real bacteremia. So let me explain it. So we know, and Alan Schroeder has provided some of this evidence in publication, that kids who are bacteremic when they have their UTI look almost identical to kids who don't. So basically, their clinical criteria, they don't look any sicker. When you compare labs, they don't look any different. And really, when you follow them and look at outcomes, they're pretty much the same. So kids with bacteremia who have UTIs and bacteremia don't go on to have more complications than kids who have UTIs and no bacteremia in general. They recover just as well as kids who don't have bacteremia. So the idea here being that, what if in those kids who we happen to have detected bacteremia when they had their UTI, what would have happened if we didn't get that blood culture? Well, the evidence in the current evidence in the literature suggests that nothing. Yeah. That they would have done just as well. That we would have treated their UTI and they would have done just as well. So that's where we feel this is evidence of overdiagnosis, because knowing that they're bacteremic doesn't lead to anything but probably just increased length of stay.
Yeah, this was a topic, UTI with bacteremia, we covered in a previous podcast. I agree with you 100%. And the literature is really, really mixed on that. That's great. And hyperbilirubinemia, how did you guys use that as an example of overdiagnosis?
Well, I think that's one of the clearest examples, because for example, back in, a few years ago, the AAP published a guideline where they sort of expanded what counts as hyperbilirubinemia. They published the famous nomogram for hyperbilirubinemia. And so a lot of people felt like what happened was the threshold for phototherapy was lowered in many instances, or it was, if you will, it was standardized for certain, but it was also lowered. So we basically defined what the illness was, right, at a certain level of bilirubin in the blood. And since the publication of that nomogram and that guideline, we know that we hospitalize many more kids with hyperbilirubinemia, the diagnosis of hyperbilirubinemia. And so again, anytime in medicine where you do more of something, and in this case we're hospitalizing more children, what you should always ask is, hospitalizing more children leading to less instances of whatever you're trying to prevent? And in hyperbilirubinemia, what we're trying to prevent is kernicterus, correct?
Right.
And well, kernicterus rates have remained fairly steady since that publication of the AAP guidelines, and we hospitalize kids way more than we used to. And so again, for us, this suggested overdiagnosis. Again, none of it is proving it. I think, to be able to prove overdiagnosis, you really have to do things like randomized controlled trials of screening tests. So none of it really proves it, but there's really strong suggestions. And certainly when you see this phenomenon of an intervention increasing that increases the diagnosis of something, but the outcome, the ultimate outcome that you're trying to prevent, pretty much stays the same, then you should be at least suspicious that you're dealing with overdiagnosis. Let me give you an example that's really close to home for pediatric hospitalists. So we know that bronchiolitis, which is, if you're a hospitalist, bronchiolitis is bread and butter, is the number one reason for hospitalization in kids. We know that bronchiolitis has an extremely low mortality rate. It really has remained constant throughout the years, the mortality rate and morbidity of bronchiolitis. Kids aren't any sicker with bronchiolitis right now than they were 50 years ago. That has pretty much stayed the same. However, since 1980, we hospitalized 300% more children with bronchiolitis. I mean, think about that, 300% more children get hospitalized since the 1980s with bronchiolitis than they used to. And again, I just told you that there's really no evidence that bronchiolitis is any more virulent than it used to be. So why would we hospitalize 300% more kids? Well, in 1980, the use of pulse oximetry became routine, right? Because we were able to detect pulse oximetry much easier, Whereas the pulse oximetry before used to be used only in labs, and it used to be these large machines that were very expensive. Right around the 1980s is when they started manufacturing pulse ox machines that were portable, easy to use, a little cheaper, so more available in hospitals. So we started using them in ERs and clinics, and we detected more hypoxemia. So now we detect hypoxemia a lot more, and so we hospitalize children with hypoxia that have bronchiolitis way more. And we know that the pulse oximetry is one of the main determinants of admission. This has been seen by several publications. Mm-hmm. I think the most creative publication that looked at this was Suzanne Shu from Canada, where they looked at the effect of oximetry in hospitalization. They published in JAMA in 2014, in August of 2014, where they actually took pulse ox and they modified them, right?
Yeah,
they actually did a randomized control trial.
I think that was in England, yeah.
Yes. Actually, this one was in Canada. I think you're talking about the Dept study, which was in England, but this one was in Canada. And they actually falsely increased the number of the pulse ox on patients with bronchiolitis by 3%, right? Now, they were all in the normoxia range, right? They were over 90%. But for example, if the patient had a 92%, it would show 95% to the physician. So by 3%, it increased it up. And they randomized kids into the regular pulse ox or this sort of false pulse ox, or the modified pulse ox, if you will. 41% of the controls were admitted. So the kids which had the actual pulse ox reading, 41% were admitted. And in the intervention, the one who had the pulse ox that was elevated just by 3 percentage points, only 26% were admitted. So we know that the pulse ox really drives in a big way the decision to hospitalize a child with bronchiolitis. I mean, these were all children who had normal pulse oxygen concentrations, right? 92 or 95%, Neither of them were below 90%, but because this reassurance of just 3 percentage points, almost twice as many kids were admitted by having just 3 percentage lowers. So we know the pulse ox drives a lot of hospitalizations. So we have increase in hospitalization, we have more detection of hypoxia, and we have exactly the same outcomes, right? Because kids aren't dying more from bronchiolitis. They're not sicker from bronchiolitis. Again, this highly suggests a overdiagnosis of hypoxemia, which has led to an increased hospitalization of bronchiolitis.
That's interesting. And that can have implications in terms of infections acquired in the hospital, viral or otherwise. And of course, if you do procedures, there's issues with that. That's fascinating. I had not heard about that study from Canada. I had read about, and we had talked about on the podcast, the British study where they modified it. But
the Dept study.
That's interesting. That's really interesting.
Yeah, absolutely. And I think, all of this was published after we had sort of pointed out in pediatrics that hypoxia is probably one of these things in pediatrics that's overdiagnosed, and I think people have studied it since. And I think I've really begun to show that really it is. There's the same group from Canada that did this study that I just told you about, did a follow-up study in which discharged 118 kids from the emergency room, again with a modified pulse oximeter. But this time, the way they modified it was they basically they silenced the alarm and they disabled the display of the pulse ox. So the parents went, these were kids who would normally have been discharged from the emergency department anyway, and they were sent home. Instead of being just sent home, they were sent home with pulse ox. But the parents couldn't tell the reading. Nobody could tell the reading except the investigators, they downloaded the information, and what they wanted to know was, what happens with the oxygen concentration of these kids that we normally send home with bronchiolitis, right? And what they found was incredible. 64% of them had desaturations less than 90% for at least a minute, and 29 out of the 118 infants had sustained desaturations to 70% or less. These are kids that we send home all the time, which means that hypoxia in children with bronchiolitis is an incredibly prevalent thing. And by the way, there was no difference in unscheduled medical visits or rehospitalization amongst these infants, which means the outcomes were exactly the same, right? And so having these momentary hypoxemic events did not lead to worse outcomes. Again, suggesting that when we diagnose hypoxia and bronchiolitis, a lot of the time, this may be overdiagnosis, right? There's no benefit to the patient from diagnosing the hypoxemia necessarily, in at least like a certain percent of these patients. And what happens? Bad things happen, hospitalizations. And there's at least one study that's been published, and about 10% of kids, particularly in pediatrics, there's some type of negative outcome when you hospitalize them, either a medical error or some type of other error in the hospital that happens when you hospitalize a kid with bronchiolitis. 10%. Now, some of these were mild errors and things that didn't cause permanent harm, but it happens in 10% of kids that we hospitalize. And so, and if we're saying that a lot of these hospitalizations are unnecessary, then you start to see how overdiagnosis of something as simple as hypoxia can really lead to significant harm, particularly when you think of the large amount of kids that we see with bronchiolitis on a yearly basis.
Yeah, wow, that's a huge number. I mean, every children's hospital in the country is full from November roughly to May.
Right.
So, Ricardo, are there other examples in pediatrics and overdiagnosis?
Yeah, I mean, like I said, we proposed some, but let me talk about some of the ones that I think there's evidence starting to emerge, right? I think head injury, for example, I think it's a really good one. We know that head injury in children is common. It's one of these sort of common things that happens from being a child. Mm-hmm. You fall, you hit your head, or you're in a bike, you fall, hit your head, or some type of other mechanism for which you get a minor head injury, and it's one of the more common reasons why kids come to the ER. And PCARN, the Pediatric Emergency Medicine Collaborative that studies a lot of the things in pediatric emergency medicine, published some guidelines or a study a few years back that really was just a really good study on head injury. Probably sort of like people called it the study to end all studies for head injury, in which they came up with the PCARN rules for head injury, in which they studied many thousands of kids with head injuries, and they looked at risk factors for having an actual bad outcome from a head injury. And so asking the question, which kids do you need to image, right? That's the question. And so this led really to a large decrease in the number of CTs that have been obtained in kids with head injuries. So, then the question remains is, can any of these findings that we usually find in head CTs, can that be considered an example of overdiagnosis? And I think with PCARN, we have seen sort of a natural experiment of maybe the fact that head injuries or the consequences of head injuries were probably overdiagnosed. So let me give you an example. So I have one of my colleagues, Eric Kuhn, is studying this. And this is a bit of unpublished data, but he's presented this before at meetings. And he's doing a retrospective cohort of head injuries in children through the FIST database. And the FIST database is this large collaborative of children's hospitals where everybody submits their data. And he looked at head injuries and their diagnosis before and after the publication of the PCARN criteria for head injuries. And I think what he found was really striking. He found that really everything has decreased. CT imaging has decreased. Skull fractures have decreased. Intracranial bleed diagnoses have decreased. Hospitalizations due to head injuries have decreased. But oddly enough, neurosurgery from resulting from minor head injuries have decreased. And so what does that mean? That means we're diagnosing less of this because a publication now exists that sort of showed us which kids we really didn't need to get imaging on. But it has also led to less diagnosis of things that we used to think were important. Skull fractures, for example. They've gone down in diagnosis, so we're diagnosing less skull fractures. But mortality from head injuries has basically stayed the same, which really suggests that if we're diagnosing less skull fractures and we're diagnosing less intracranial bleeds, that means that some of these weren't causing any problems to begin with, right? Because mortality has basically stayed the same. If it was bad to diagnose less skull fractures and less intracranial bleeds, then we'd see mortality or morbidity going up, and we haven't seen any of that. In fact, Eric's data suggests that the opposite has happened. It has remained stable. That means that a lot of the diagnoses that were being made of skull fractures, of intracranial bleeds, were examples of overdiagnosis. Again, they were real diagnoses. Kids actually had skull fractures. They actually had these small intracranial bleeds or some subdural hematomas, but it didn't lead to any bad outcomes, right? In fact, we see that outcomes have remained the same despite the fact that we diagnose them less. So this is sort of like the inverse of what I've spoken about before, where we actually see an outcome or a diagnosis going up and the outcome stays the same. In this instance, we're seeing a diagnosis going down, but we actually see the same sort of outcome. That means that we were probably doing too much before, right? And now we're doing a better job of addressing the problem of head injury. So I think this is another example of an instance in pediatrics in which we're probably overdiagnosing kids. And since we've seen hospitalization rates going down, that means we were causing harm, right? We were causing instances in which hospitalization was occurring, probably unnecessarily. And even neurosurgery has gone down. So what does that mean? Does it mean that we were doing some neurosurgical procedures which were unnecessary? Certainly, this data doesn't prove that, but it's very compelling, and it suggests that we were doing too much.
That's just interesting, because when you think of a diagnosis like skull fracture, and the first gut instinct as a physician I have is we should probably know if a child has a skull fracture or not. But what you're suggesting is, short of there being obvious symptoms or issues, it may not be as relevant as we think.
Right. Yeah. No. And you just hit the nail on the head of why it's so difficult for physicians to understand overdiagnosis. Is because why would you think knowing that a child has a skull fracture would be a bad thing? Well, if on a single patient level in which they see a smart physician who thinks about the problem deeply and thinks, well, yes, he has a small skull fracture and it's probably irrelevant and it's not going to cause a problem. You may not see the big picture, but if you think about it, our most common reaction to a scary diagnosis, such as head injury, is to be very cautious. And usually very cautious means that we do things, right? My colleague, Alan Schroeder, has pointed out a lot of the time that medicine, pediatrics is no exception, we use the term conservative different than what we use it in politics, right? When we're talking about a conservative politician, we're talking about somebody who's fiscally conservative. They don't want to spend money. But in medicine, we do the opposite, right? When we say we're being conservative, we actually spend more. Yeah. Well, we're going to be conservative and admit this child to the hospital, which is, a very expensive thing to do. Or we're going to be conservative and get this lab test or this blood test or this CT scan. And so it's sort of like the opposite. And so I think knowing something, such as somebody has a skull fracture, or forget a small head bleed, leads us to do more things. And those things that we do more are hospitalization. But oftentimes, when the child gets hospitalized, somebody's going to want to repeat that head CT, right? So not only hospitalization, but repeat imaging. So one CT, which probably didn't need to be obtained, led to a diagnosis that probably didn't need to be obtained, and it led to an action, a hospitalization, which probably didn't need to be done. And during the hospitalization, more things are done, such as repeat head imaging, etc., that don't need to be done. So it's a cascade of events that usually results from the overuse of imaging studies that leads to overdiagnosis. So, I've talked about overuse. I've defined it. I've told you that overuse is made up of overtreatment and overdiagnosis. We talked fairly extensively about overdiagnosis, gave you some pediatric examples. And so I think, hopefully, I've convinced you and your listeners that, this is a problem, this is an issue. And so, what do we do about it? Well, a lot of things are happening. One of them that I participated in was the Choosing Wisely campaign. I think that campaign has really been at the forefront of this overuse dilemma, overuse conversation. The American Board of Internal Medicine Foundation, which is sort of the charity arm of the American Board of Internal Medicine, came up with this campaign that they called Choosing Wisely a few years ago. And what they did was they invited several medical societies to participate. And, they first got several adult medical societies to participate in the first round of recommendations. And then they invited several other societies and included pediatric societies. And the society that I was very fortunate to participate in was the Society of Hospital Medicine. As you know, the Society of Hospital Medicine, they have both adult and pediatric representation. So what the Society of Hospital Medicine decided to do was to really have two lists, one list for pediatrics and one list for adults. And this is what the ABIM Foundation asked societies to do, is to come up with a list of 5 therapies or tests that are overused in their particular field. And the purpose of this was to start a conversation. It was really meant more for the public. They wanted to have a website in which they featured all those recommendations. And that website is currently up. If you go to choosingwisely.org, you can see it. And basically, that movement really took off. And now there's over 70 medical societies which have participated. And, a lot of them have pediatric participation. Ours happened to be the first one that was a pediatric participation. As I said at the beginning of our talk here, is that really pediatric hospitalists and hospitalists in general have been at the forefront of this. And so it wasn't really surprising to us that we got really excited about participating in this endeavor. And so I led the Pediatric Society of Hospital Medicine Choosing Wisely campaign. And our task was really to develop a list of 5 things that we believe were overused in pediatric hospital medicine. And so we published this list back in 2013 in the website. We had a group of pediatric hospitalists throughout the country. We vetted the different options in the Pediatric Hospital Medicine listserv and in several other listservs. We did a modified Delphi process to come up with the last, with the most, with the top 5, if you will. But we decided we also wanted to publish our methods and our list. And so we through the Journal of Hospital Medicine, we did concurrent publications with our adult colleagues, and we published our list. And what did we come up with? We came up really a list that would be unsurprising to any pediatric hospitalist, with maybe the exception of one of the things in the list, and I'll tell you why we chose that one. And the list was as follows. We said, don't order chest radiographs in patients with asthma or bronchiolitis. Don't use bronchodilators in children with bronchiolitis. Don't use systemic corticosteroids in children with lower respiratory tract infections. Don't treat gastroesophageal reflux in infants with acid suppression therapy. And don't use continuous pulse oximetry routinely in children with acute respiratory illness unless they're on supplemental oxygen. Now, the gastroesophageal reflux one, it was in there, and, we thought about it long and hard about, well, this isn't really something we see or that we treat a lot as pediatric hospitalists, because usually kids come in with treatment for this. But we felt the evidence for this was really strong. Lots of randomized control trials showing that reflux meds in kids really don't work, and they're used all the time. And so we felt that the evidence for it was just very strong, and that the evidence of futility and the evidence of harm that started emerging then and now really has been solidified in kids with increased lower respiratory tract infections, increased GI infections, and other bad events. It really was strong, and so we decided to keep that one in there. But all the other ones are respiratory ones, right? The things we commonly see: asthma, bronchiolitis, lower respiratory tract infections. And I think, this list, which at the time generated a little bit of controversy because we had things in there such as don't use continuous pulse oximetry routinely, really has spurred a lot of quality improvement work, which really was our aim. We actually said in the paper, our aim is for people to use this list for quality improvement projects. And there have been at least 2 or 3 publications since our list was published of people actually trying to do a better job. So this has been one effort of many that have spurred people on to action and to try to do a better job. Other things I think that are being done or have been done is, for example, publication of negative guidelines, So not just guidelines that tell you what to do, but guidelines that tell you what not to do. The AAP guidelines of bronchiolitis is a great example of this. 10 of the 14 recommendations start with physicians should not. Really telling quotes in bronchiolitis that I think explains just about everything you should know in bronchiolitis. And bear with me, because it's a nice quote that I think your listeners should really hear. And it is a quote that says, "Since acute viral bronchiolitis is thus a self-limited disease of relatively good prognosis, the principle of primum non nocere, first do no harm, should temper frustrated anxiety to do anything to relieve severe dyspnea. His energies, the patient's, should not be frittered away by the annoyance of unnecessary or futile medications and procedures, and rest should be treasured." Now that quote, you would think would have come from the new AAP guidelines on bronchiolitis, because that's exactly what we do for bronchiolitis, right? Mm-hmm. We try to annoy the patient as little as possible, and we try to prevent interventions as little as possible. But that quote actually came from an article by Drs. Wright and O'Beam from 1965.
Is that right?
Yeah. So back in 1965, they already knew that there's very little we can do for bronchiolitis. And the AAP guidelines nowadays are an incredible reflection of what Drs. Wright and O'Beam already knew in 1965, that a lot of the things that we do in bronchiolitis are futile, and that, guess what, kids get better anyway.
Well, that was great. Now, I'm going to put you on the spot, Ricardo, because as I've been listening, I've been writing along, and I have overuse, and you defined it in overdiagnosis and overtreatment, errors of omission, errors of commission, and there's numerous examples of overdiagnosis. And for our listeners, we've been really hitting the core competency of cost-effective care during this podcast. So now that we have a board examination coming up, if I can put you on the spot and say, of this, how would you put this in a test format?
Well, that's a tough question. Because you're right. It doesn't lend itself to the regular clinical questions, but I think we can incorporate it into clinical examples, right? So you could potentially have a question in a board exam about a child who gets admitted for pneumonia, and have a list of things that you could possibly do. And, the least invasive thing is usually the right answer. So not getting blood cultures, not getting CVCs, treating that child with the lowest spectrum antibiotic is probably the right thing to do. VIP collaborative, the Value in Inpatient Pediatrics collaborative, that is done through the AAP, that is led by hospitalists, that looked at pneumonia, really emphasized a lot of these principles of trying to do less for patients with pneumonia, right? And so those are part of our literature now. The fact that we should be using ampicillin for treating kids with pneumonia, and that a CDC is not indicated. It's not only in our literature; it's part of our guidelines. So I think a lot of the guidelines where these questions are going to come from are going to emphasize this cost effectiveness, evidence-based treatment, which essentially ends up being the same thing. So I think, so I just gave you an example of negative guidelines, some progress that has been made, an example of a collaborative, choosing wisely, that it emphasizes this. But I think there are things that we could do on a day-to-day basis to sort of embrace this thing of safely doing less. Comparative effectiveness research, for example. I know that randomized control trials are the standard for testing things, but there's a lot of things that we do already that we need to test it against other things, So a lot of this research that's being done in comparative effectiveness, I think, is going to lead to a lot of improvements in this type of things. But I think, even things, the way we approach medicine in general, the way we teach it, for example, is important. We talked about how sometimes making a diagnosis is not the right thing to do. I think that's the way we should teach medicine. We all deal with trainees. We teach them to come up with these zebras when really, we should be telling them that most of the things that we see are not zebras. And then when you think of think of a broad differential diagnosis, but think broadly, but act narrowly. Only get test B and C if test A is negative. Don't get everything at the same time. I think we should emphasize that our purpose should be not to, and I think Alan Schroeder has talked about this, not that we should come up with diagnosis all the time in morning reports, but that the aim of morning reports should sometimes be to make the patient better, right? And to make the patient better, sometimes we don't need to make a diagnosis, or we don't need to get a certain test. There have been really creative examples of people who have done morning reports in which the goal is not to come up with these rare diagnoses, but the goal is all of a sudden to make the patient better, which is really what we all want to do. And then when you take that approach to teaching medicine, you learn that there's things that you really don't need to do. I think our other approach that we need to teach with trainees is to tell them that there are no benign interventions. What could be a more benign intervention, for example, than rest, right? I mean,
it's true.
That's probably one of the things that we were taught. One of the first things we were taught that we should tell patients, if you're ill, you should rest. But sometimes even interventions such as rest may not be benign. There was a publication in Pediatrics in 2015 which looked at strict rest versus usual activity for patients who have suffered a concussion. And what they found was that strict rest was not a good thing to do, that they should resume activities as soon as possible. What strict rest led to was less school attendance, and it led to more self-reported longer durations of symptoms. And so the patients that resumed usual activities faster, actually their symptoms lasted less. So even things like rest is not a benign thing. There are no benign interventions, and we should tell that to our trainees. Similarly, there's no unquestionable practices. Absolutely no unquestionable practices. Prasad and colleagues published a great study about in August of 2013, where they analyzed all articles published in a decade from 2001 to 2011 in a very prestigious journal. And they looked at articles that tested established therapies versus new ones, where they basically tested the standard of care. And what they saw was fairly striking. About 40.2% of the time, the standard of therapy was reversed. So think about that. 40.2% of the time when we tested the standard of therapy against something new, it was reversed. And in only 38% of the cases was the standard of therapy reaffirmed. So really, there are no unquestionable practices. So I think these things are the ones that we need to realize, that we need to know, that we need to teach our trainees, that remind them that unanticipated harms occur frequently. We should reevaluate what we accept as the standard of care. Again, we should redefine the word conservative, right? When we talk about medicine, it should not be doing more. It should really be about doing less. We really should introduce sort of this safely doing less concept. And instead of using phrases such as, to be safe, let's just watch him another night, why don't we think about this as, well, to be safe, let's take his IV out and send him home, right? And because I think that introduces the concept that we should all remember is the first concept that we should remember, which is the concept of first do no harm. That's it.
I couldn't agree more. That was great. It's really something to think about that we don't hear often enough. I don't think we do. Now, we're gonna wrap up now. So I would like to say, first of all, to Dr. Ricardo Quinonez from Texas Children's in Houston, thank you very much for being on. This was a great talk. This was a great podcast. I really appreciate your time.
No, thank you. I really appreciate the opportunity to talk about this. As you can probably tell, I'm always very excited to talk about this. And again, this is a new format for me, and so I think the more ways we can spread this message, the better.
I agree. And then for other acknowledgments, I have to thank the University of Pittsburgh and remind my listeners you can get free Category 1 AMA CME credit for this podcast. Follow the link on the site you downloaded the podcast to, and you can log in and get free CME credit for listening. I also want to thank the Diagnostic Referral Group here at the Children's Hospital of Pittsburgh for supporting this podcast and allowing me to do this. And of course, I want to thank Dr. Megan Keene Tarchichi, who always helps me out with everything. And all the listeners who are listening, thank you very much for listening and downloading. I really appreciate it. Our next podcast, we're going to have a two-parter coming up, which is going to focus on pneumonia. I'm going to split it up into bacterial community-acquired pneumonia and then viral and atypical pneumonia will be another podcast. So that should be after the Pediatric Hospital Medicine Conference. And again, Ricardo, I'm sure I'll see you there in July in Nashville. It should be a good time.
Absolutely.
And if anyone is listening and has suggestions or comments, feel free to email me at tony.tarchichi, tarchichi, at chp.edu. That's at chp.edu. Thank you all very much. I will see you at the next podcast or at the conference.